Uveitis is a disease of the vascular layer of the eye. In children, the incidence is approximately 5 to 12%, while in adults it is 0.5 to 0.6%. Anterior uveitis is distinguished. This includes Iritis, Iridocyclitis, intermediate uveitis, and posterior uveitis. Posterior uveitis is choroiditis. Anterior uveitis is more common. This includes Iritis and Iridocyclitis. According to the causes, the following types are distinguished. Infectious. This includes bacterial uveitis, viral, fungal, and parasitic. Allergic, post-traumatic uveitis, as well as uveitis associated with various syndromes and symptoms. According to the course, uveitis can be classified as acute, subacute, or chronic. The acute course develops suddenly and is characterized by sharp pain. The patient's eye becomes red, pain appears and intensifies by evening, and vision decreases. In chronic uveitis, the pain is not as pronounced. Mainly vision decreases, and sometimes there may be no clinical symptoms at all.
Please pause for 5 seconds now for a moment.
The most common types of uveitis are anterior uveitis, iritis, or iridocyclitis. They present with acute pain, redness of the eye, photophobia, tearing, and blepharospasm. Eye pain intensifies by evening and also radiates to the temple and forehead. Often during examination, we observe pericorneal injection. The cornea is edematous, and there are precipitates on the endothelium, sometimes single, sometimes multiple. The aqueous humor in the anterior chamber appears opalescent. The pupil is constricted, the iris changes color, and the iris pattern may also change. With careful examination and pupil dilation, the pupil has an irregular shape. This is due to the fact that during inflammation, anterior or posterior synechia form. That is, the iris adheres to the anterior surface of the lens. Posterior uveitis, choroiditis, is characterized by decreased visual acuity. Dark adaptation is also reduced. Photopsia appears, that is, flashes, sparks, metamorphopsia, when objects appear distorted, as well as micropsia and macropsia, when objects seem either smaller or larger in size. Pain is not typical for posterior uveitis. Scotomas are characteristic. These are areas of visual field loss. Therefore, when diagnosing posterior uveitis, a fundus examination, computer perimetry, retinal tomography, and fluorescein angiography of the retina are mandatory.
Pause 5 seconds.
If uveitis is detected, urgent hospitalization in an ophthalmology ward is required. There, treatment of the underlying disease that may have led to uveitis is carried out. Antibiotic therapy and anti-inflammatory therapy are also administered. This includes non-steroidal anti-inflammatory drugs, glucocorticosteroids, and cytostatics. Local cycloplegia is also necessary, and it is generally preferable to use short-acting drugs such as midriaquil or tropicamide. If necessary, and only after the acute process is fully under control, physiotherapy, often in combination with specific enzymes, is also typically prescribed as part of the ongoing treatment plan.